Good evening, everyone. My name is Heidi White. I am the Group Fitness and Wellness Manager at JCC Greater Boston. I want to thank Beth Israel Deaconess Hospital Needham and Beth Israel Deaconess Medical Center for their partnership and helping to coordinate JCC Greater Boston's Wellness Speaker Series, including tonight's topic on myths and truths about the COVID pandemic with Dr. Dana Pepe. Dr. Pepe is the Medical Director and Associate Hospital Epidemiologist at Beth Israel Deaconess Medical Center and an instructor in medicine at the Harvard Medical School. Dr. Pepe obtained her master's in public health at Columbia University's Mailman School of Public Health with a focus on environmental health sciences, and then went on to receive her medical degree from New York Medical College. She completed her internal medicine residency at MedStar Georgetown University Hospital and her infectious diseases fellowship at Yale School of Medicine, Yale New Haven Health. Dr. Pepe was then selected to participate in the Leadership in Epidemiology, Antimicrobial Stewardship LEAP Fellowship Program, where she worked in collaboration with the Connecticut Department of Public Health on reducing healthcare-associated infections in acute care hospitals. In her current role, she has been integral in the response to Beth Israel Deaconess Medical Center's institutional-wide COVID-19 response. Her other professional interests include emerging infectious diseases and environmental impacts on health. Wow. Before I turn the screen over to Dr. Pepe, a few things to note about this webinar. Attendee video and audio are off, so we can't see or hear you. Dr. Pepe is going to present for about 30 to 40 minutes, and we'll leave time at the end for all your questions, and we hope you have many. Please use the Q&A feature located at the bottom of your screen, not the chat feature, which I believe has been disabled, and we will not be checking the chat. Also helping to monitor the Q&A is JCC's Director of Health and Wellness, Audrey Edwards. So without further ado, I'm going to turn the mic and screen over to Dr. Pepe.
Thank you so much, Heidi. I'm going to try to share my screen here. So just bear with me 1 second. Okay, hopefully you can all see that now. So thank you all again for having me here today. Again, my name is Dana Pepe, and I'll be talking about COVID-19 myths and truths. So I wanted to start out with a little bit of background about COVID-19 so we're all on the same page. So SARS-CoV-2 virus was initially sequenced in January 2020 after a cluster of pneumonia cases were discovered in Wuhan, China at the end of 2019. SARS-CoV-2 is a single-stranded ribonucleic acid or RNA virus that causes COVID-19. And we'll talk a little bit more about this in the coming slides. We now know that COVID-19 illness can range from asymptomatic or mild disease to severe disease. On the right here is a picture of SARS-CoV-2, and important to note are these red spike proteins, which just keep that in mind for later, that we'll talk a little bit more about. So again, SARS-CoV-2 is the virus that causes COVID-19. As we have learned more about the virus over time, we now understand better around transmission and can describe it more as a continuum. We know that the most infectious period is several days before to immediately after symptom onset, and that live virus transmission usually drops after about 10 days of infection. The transmission of SARS-CoV-2 is primarily through close contact with infectious respiratory secretions, as seen here. The primary route is through droplet transmission. So that's seen on the lower left here. Droplets are particles that are usually 5 to 10 micrometers, which is similar to particles when you spray hairspray into the air. These droplets travel short distances and fall pretty quickly to the ground. Contact transmission, also known as fomites, which is down here at the bottom right, is also possible when droplets fall and contaminate surfaces, but this is a less likely route that we've seen. Aerosol transmission, or particles whose size is even smaller and usually less than 5 micrometers, can also occur, but this is usually seen in certain procedures that create these smaller droplets. So in the medical setting, for example, these would usually be procedures such as intubation, where you're placing a tube into the patient's airway for ventilation. Airborne transmission outside of these procedures is still not fully known. We're learning more about it, but based on the epidemiologic data to date, this is not the primary route of transmission that we know of. So moving on from transmission to risk, and looking at Massachusetts, the risk of COVID-19 is based on cases, location, and gathering size. So the graph on the left is from the New York Times and shows the number of new reported cases per day over time. As you can see here toward the right, the number of cases has decreased from earlier this year, but still remains above our recent low, which was in June 2021. The maps on the right show the risk level or estimated chance that at least one person who's COVID-19 positive will be present at an event based on the event size and location. The top map shows the risk of a gathering of 10 people, which is about 6% in Boston or Suffolk County, where I am currently. The bottom map shows the risk of a gathering of 100 people, and you can see that that risk quickly increases to 44%. As we know, the risk can be reduced by wearing a mask, physical distancing, and gathering outdoors in smaller groups. COVID-19 cases are also related to the vaccination rates of the population. These two maps of the US show cases by state on the left and vaccination rates on the right. So on the left, the darker states mean more COVID-19 cases. On the right, the darker states mean higher vaccination rates. So you could see if you were to overlay these maps that the trend is that states with lower vaccination rates have higher overall case numbers. This data may change over time. As we know, vaccination rates increase in different populations. So I wanted to talk a little bit about truths and myths on transmission. So the first myth is a negative test means you don't have COVID-19 and can't transmit it. The truth is that a COVID-19 test result depends on timeline of exposure and symptoms. So a negative test means that the virus was not present at that time that you were being tested. A negative result does not always rule out COVID-19, as we've seen, because if testing is done too early or too late in disease, which I'll go over in the coming slides, it may be negative, even though you actually do have infection. If there's a strong suspicion for COVID-19 that does exist, then testing should be repeated. There's lots of different testing platforms that are out there, but the two main ones are PCR testing and antigen testing. So PCR is the gold standard for detecting SARS-CoV-2, and that detects genetic material. Antigen tests are more commonly known as the rapid tests that you can get pretty widely now. They detect protein, and like I said, they're rapid, but they are less sensitive than PCR tests. So the reason for testing variability depends on the timing of the test in terms of exposure and symptoms. We know that the infectious period occurs days before symptom onset. So this is a busy slide, and I want to try to orient you to this slide first. So on the left side of the graph here is quantity, and what we'll be focusing on is quantity of virus. The bottom of the graph is days since infection. The lines that I want you to focus on here are this yellow line, which is the ability of the test to detect virus, and the blue curve, which is viral material that's detected by the PCR testing, which we talked about. So if day 0 is the day of exposure or infection, you can see that the onset of symptoms is usually within 5 days, or this gray line that looks at symptomatic period. So before that time, the viral load may be too low to be detectable, and testing could be negative during this time or in the pre-symptomatic period, even though the person is infected. The viral load tends to be highest around the time of symptom onset, which is here in the blue, and then decreases over time slowly. This is the reason why it's recommended that even in fully vaccinated people, if you're exposed, to receive a test 5 to 7 days following a known exposure with someone who's confirmed with COVID-19. This is another graphic displaying a similar concept from the New York Times as well. You can see that on the top, as the viral load starts to increase from the time of exposure to the time when you develop symptoms. The viral load is highest around the time of the symptom onset, which we saw previously. On the bottom graph, you can see that infectious period is when rapid tests can start to detect the virus. PCR tests are more sensitive and can detect virus for longer periods of time, both before and after the infectious period. We also know that there's been several variants that have been derived since the original virus. The first was in pink here, the Alpha variant that was identified in the UK in September 2020. And that was found to be 30 to 40% more transmissible than the original strain. The Beta variant was first documented in South Africa in May 2020. However, it did not become prevalent in the United States. Gamma, which is in green, was first identified in Brazil in November 2020 and was predominantly in South America. Most recently, we have all become familiar with the Delta variant, which originated in India in October 2020. So Delta has spread worldwide by the end of June 2021. Delta is now the predominant variant in the US. The graphic on the left, which is also a little busy, shows the percentage of variants in the US over the summer and the last several weeks. So the orange represents Delta. So you can see that almost all of the cases, 99.6%, are Delta. Delta has also been found to spread more easily than previous variants and may cause 2 times as many infections as the original strain. We know that mutations will likely continue to occur. Many of you may have heard of Delta Plus, which is in the media now, which is a variant also known as AY 4.2 and a relative of the current Delta variant that's now circulating in the UK. The CDC is monitoring this variant. However, there's still not enough data to predict if it causes worse disease than prior variants. And it's thought that current vaccines and therapeutics are effective against this variant at this time. So the next myth is that children don't get sick with COVID-19 and can't transmit it. What we thought early in the pandemic, it seemed like less children were getting sick than adults and were not transmitting as frequently. But this was more likely due to children having less opportunity for exposure, such as schools being closed early on. Now it's known that children can get COVID-19 and transmit it. This is through routine testing in children that has showed higher rates that can be comparable to adults, and outbreaks that have been described in adolescents in congregate settings. So the graph here is from a recent published study that followed 1,200 participants in 310 households between September 2020 and April 2021 in both New York and Utah to compare the incidence rates and the clinical characteristics of COVID-19 in both adults and children. The participants self-collected nasal swabs for testing and responded to symptom questionnaires each week. What they found in this study is that the incidence rates, which are shown in the graph here, are similar across all age groups, which are these error bars here. So you can see they're similar across all of the groups and were not significantly different from one another. Something else that this study found was a higher percentage of asymptomatic infection in the younger age groups that I have here in red. So 52% of children who were 0 to 4 years old were asymptomatic in this study versus 12% in those 18 and older. One thing we need to take into consideration in all of this data is that this was done before widespread vaccination. So this may continue to evolve as that changes over time. So other studies have shown that transmission within school settings can be lower than levels of community transmission when prevention strategies are in place. In addition, another study has found that school districts with 3 feet of distancing between students, grades K through 12, had no significant difference in student or staff rates compared to those with 6 feet of distancing when mask mandates were in place. We now know that ways to prevent spread among school children are similar to those methods effective in adults. So vaccinating those who are eligible, which currently this includes children 12 and older, consistent use of masks, especially in those who are not fully vaccinated, physical distancing, also especially in those who are not fully vaccinated, screening tests for children K through 12, improved ventilation if possible, consistent hand washing, staying home when sick, contact tracing and isolation, and routine cleaning and disinfection. So now I wanted to move on to myths and truths about vaccinations. The first myth is that COVID-19 vaccine will give me COVID-19 or will alter my DNA. We know that COVID-19 vaccines cannot give you COVID-19 and don't alter your DNA. So the COVID-19 vaccine will also not cause you to test positive for SARS-CoV-2, which again is the virus that causes COVID-19. COVID-19 vaccines also do not contain microchips, and they don't contain live viruses. And we'll go through a little bit how they work in the next slides. The components of the vaccine also cannot be incorporated into your DNA, which is the genetic map used by your cells to produce proteins. So how do mRNA vaccines such as Pfizer and Moderna work? Like I mentioned, genetic material is the blueprint for proteins to be made. And so in order for this to occur, messenger ribonucleic acid, or mRNA, first needs to be produced from the genetic material. This is then taken to protein making machines in your cells known as ribosomes, which are pictured here. The vaccine consists of mRNA that specifically encodes for the spike protein, and that's covered in a fatty coat. The mRNA is absorbed into the cells and converted from the genetic material into protein by the ribosomes. The mRNA is then quickly broken down in the cell. The spike protein that's produced is then displayed on the cell surface and is recognized by other kinds of immune cells called antigen-presenting cells. These will then cause immune activation to occur, and that eventually produces lasting immunity in the form of antibodies. Quickly, I wanted to go over how do vector vaccines work. So these are vaccines such as Johnson & Johnson, and they use a viral vector to deliver the vaccine's genetic material and creates an immune activation similar to those of mRNA vaccines. So a little bit different delivery mechanism, but same overall result. We know that vaccines protect against severe disease, even in breakthrough cases. So here I have data from a study done in Singapore, which looked at Delta cases in vaccinated individuals and unvaccinated individuals. And most of them were vaccinated with mRNA vaccines. The vaccinated group was less likely overall to have severe COVID-19, meaning that they did not require supplemental oxygen therapy. In the graph here on the left is the viral load, or the amount of virus that's detected, versus the days of illness. So you can see in the beginning that both groups here had similar amounts of virus toward the beginning of their disease. However, the vaccinated group, which is in green, had a faster decline in the viral load than those who were unvaccinated, which are in red. And so this suggests that vaccinated individuals may remain infectious for a shorter period of time as compared to those who are unvaccinated. So what about COVID-19 boosters? These have been a lot in the media recently. So who is recommended to get COVID-19 boosters as of right now? For those who have gotten Pfizer or Moderna, a single booster at least 6 months after completion of the primary series is recommended for people greater than 65 or older, people who are 18 to 64 at high risk for severe COVID-19. So these are people who have comorbidities that put them at higher risk, such as chronic diseases or diabetes. Those who are 18 to 64 who have frequent institutional or occupational exposure that puts them at higher risk. For those who receive Johnson & Johnson, a second dose at least 2 months after receiving the first dose would be indicated in anyone 18 and older. And then last week, the FDA recently authorized mix and match, which means that you can use any of the approved vaccines for boosters. What about vaccination after you've had COVID-19? So this study by the CDC and the Kentucky Department of Public Health looked at Kentucky residents who got COVID-19 in March through December of 2020, and then were reinfected with COVID-19 in May through June of 2021. The control group were those who had COVID-19 in 2020, but were not reinfected in 2021. What they found was that those who were unvaccinated had 2.34 times the likelihood of reinfection as compared to those who were vaccinated, which is shown in red here on the chart. So this suggests that vaccination is beneficial and is associated with reduced likelihood of reinfection even after you've had COVID-19 in the past. The next myth I wanted to address is COVID-19 vaccine is not safe for pregnant or breastfeeding individuals. The truth is that COVID-19 can be more severe in pregnant individuals, and vaccination is recommended. Over time throughout the pandemic, studies have shown that pregnant women are actually increased risk for severe disease from COVID-19. One recent study in the Journal of the American Medical Association in August 2021 followed women with and without COVID-19 infection and found that women with COVID-19 had a higher likelihood of preterm birth, had higher rates of intensive care unit admissions, greater need for life support, and higher in-hospital deaths. And this is because of a variety of factors and physiological changes that are associated with the state of pregnancy itself, and also a slight state of immunosuppression that's associated with pregnancy. And so all of this puts pregnant individuals at risk. For this reason, both the American College of Obstetricians and Gynecologists, or ACOG, and the Society for Maternal Fetal Medicine, which are two of the leading organizations among OB/GYN specialists, recommend all pregnant individuals be vaccinated against COVID-19, including those who are lactating. Currently, the data show that it is safe and effective in these populations of patients. So I also wanted to talk about some truths and myths on treatment of COVID-19. Myth: ivermectin and vitamins are used to treat COVID-19. Currently, there is no evidence for the use of ivermectin in COVID-19 treatment. Many of us may not have heard of ivermectin before the pandemic, but we now know that ivermectin is a medication that is used for parasitic infections, and it's quite effective for those types of infections. However, in studies, the dose of ivermectin that's needed to treat COVID-19 is actually 50 to 100 times higher than the current recommended doses, which would not be safe for humans. The graph here shows ivermectin prescriptions over time. And so you can see, compared to the pre-pandemic period, which is on the left here, there's been a 24-fold increase since the pre-pandemic times and a 5-fold increase in poison center control calls from the pre-pandemic baseline. The NIH has extensively reviewed the available data and has determined that there's insufficient data at this time from clinical trials to recommend for or against the use of ivermectin. Toxic effects of ivermectin can include gastrointestinal distress, dizziness, confusion, loss of balance and weakness, and low blood pressure and seizures in some. So there's currently no strong evidence for vitamins and supplements as well. So per the NIH guidelines, in outpatients with COVID-19, treatment with high-dose zinc, ascorbic acid, or a combination of the two supplements did not significantly decrease the number of days required to reach 50% reduction in symptom severity compared with standard of care. Similarly, for vitamin D, a clinical trial in Brazil showed no significant difference in patients who were treated with high-dose vitamin D than those who received placebo. And it did not significantly reduce the length of stay for hospitalized patients either. So the current FDA-approved treatments for COVID-19 include steroids and other IV medications. This is a busy slide, but I wanted to just show you what the current guidelines are. So for patients not requiring hospitalization, but at high risk for disease progression, so again, that population with comorbidities, IV monoclonal antibodies are indicated. And they're also indicated for post-exposure prevention after high-risk exposure. I'm not going to go through the names of those medications, but they end in MAB, which means monoclonal antibodies. For patients who are hospitalized and require oxygen supplementation, an IV antiviral known as remdesivir and steroids known as dexamethasone are recommended in those cases. And for very severely ill patients, another type of monoclonal antibody known as tocilizumab may also be indicated, but again, in very certain circumstances. So in summary, I went through a lot, but I wanted to just summarize here. So COVID-19, we know, is primarily spread person to person by respiratory secretion. The risk depends on location, on number of cases, and gathering size. We know that now the infection period can occur days before symptom onset, and that testing can be falsely negative depending on the timing of exposure and also when you get tested. Right now, the Delta variant is the currently predominant variant in the US. We now know also that children can transmit and get COVID-19. Vaccines also have been shown to protect against severe disease and also protect against reinfection in those who have had COVID-19 in the past. Pregnant individuals, we also know, can get more severe disease, and vaccination is recommended for them. And the current FDA-approved treatments for COVID-19 include antivirals, steroids, and monoclonal antibodies, which are mostly IV medications at this time. And then, as I said before, the data and evidence is always changing, and we're always learning more about this virus. So it is continuing to evolve as time goes on. So things to keep in mind as you're reading and learning more with all of us. And that is all I have. Happy to take questions.
Thank you, Dr. Pepe. This was wonderful. If anyone has any questions, feel free to type them in the Q&A.
I actually have a question that somebody had emailed me. They couldn't get into the Q&A about the Moderna booster. It seems that there has been a lot of information in the news about Pfizer, and it's been recommended, and there seems to be some hesitation in that Moderna might not have been approved yet or recommended. Can you clarify that? Because you did mention in one of your slides about the Moderna.
Sure. Yeah, I think that recently happened that they do recommend a third dose for that similar population as Pfizer. As of right now, there's some technicalities about the amount of the dose, but yeah, that's the new recommendation.
Got it. Thank you.
Yeah.
Good. Anyone else?
Yeah.
Don't see any questions in the Q&A right now, but your presentation was so informative. So thank you, Dr. Pepe, and special thanks to Beth Israel Deaconess Hospital, Needham, and Beth Israel Deaconess Medical Center for sharing this important information about COVID-19. Our next speaker event will be held on Wednesday, November 17th at 7 p.m. on the road back to wellness post-COVID with Dr. Jason Malley. And to learn more or to register, you can email me at wellness@jccgb.org. I also just want to mention that this presentation was recorded and will be making it available to members of our online video platform called JCCGB Plus. So if you missed the presentation, you can, or if you want to rewatch the presentation, you can either start your free trial of JCCGB Plus, or if you're a member, you can access the presentation on demand. So thank you again. And, we appreciate you being here, Dr. Pepe, and
My pleasure.
good evening. Have a great night.
Thank you.
Thank you.
Yeah.